Taussig-Bing model. So you see the anterior aorta coming off the right ventricle, and the typical sort of side-by-side vessels that are halfway between being side-by-side and being in AP relationship, but the aorta anterior and to the right. And here the coronaries, you can see the left coronary coming from sinus 1, dividing into circumflex and LAD. If we peel the atrial appendage back, you can see the right coronary in the AV groove here, coming from sinus 2. So actually the coronary anatomy is type A, the commonest variety, which is not so common in Taussig-Bing, but you see how the left coronary is coming right in front of the pulmonary artery, so it's going to be important that we sit it up high up here when we transect and reimplant the coronary. So in terms of the VSD, if we then look through the tricuspid, here's the right atrium. So we have to look through the tricuspid valve. Let me just try and get you an angle. As you can see past my fingers. But here's the tricuspid valve, and the VSD is here. So my forceps are through the VSD, which is perimembranous, and you can immediately see how awkward it is to access the VSD in a heart like this through the tricuspid valve. But you can see the inferior most component of the VSD there, close to the tricuspid valve leaflets, which are here. So we're going to get a much better view of the VSD coming from above through the right ventricle, and that's how we're going to approach it. So here's the model on the rig, and we're just making the right ventriculotomy. So you need to choose a spot where you start well below the aortic valve, because the aorta always comes a little bit deeper into the heart than you might imagine. So you make your incision a little bit lower down first, and then have a look inside and get your landmarks and your bearings and decide what you need to do. And then you can extend it a little bit further north, and you just start to free things up. Sometimes there are little trabeculae underneath you here that you need to get rid of to really give you the optimal view. Stay sutures are really helpful, but you really do have to work with your assistant so that you deliver the heart into your view and not into your assistant's view. And so the right tension on the stay sutures is really important. So now we're looking down from above to assess the position of the VSD. So I'm just picking up the leaflets of the tricuspid valve here. And the VSD is just at the top, so it's just out of view at the moment. And what you're trying to do is picture in your mind's eye the pathway that your patch is going to need to take to come around the margins of the VSD, avoiding the conduction, which will be inferior here, and then coming up around the pulmonary valve, which is deep in the heart there, and coming up onto that ridge of muscle, which is really the infundibulum between the aortic and the pulmonary valves. So again, just taking a few minutes to orientate yourself and establish how you're going to do this is really important. You can see by the perimembranous nature of the VSD that there's no way that you could commit the VSD through to the anterior aorta without obliterating the pathway to the pulmonary artery. And that's the pathway that your VSD patch needs to take onto that ridge of muscle between the pulmonary artery infundibulum and the aortic infundibulum, then around and back down to where you started. So this is the first suture going in, right down close to the septal leaflet of the tricuspid valve, but on the inlet ventricular muscle, and deliberately stepping away from the edge of the VSD so as to avoid the conduction tissue. And that's the double-armed suture in place. And now we close off the corner by taking it through the hinge point of the leaflet of the septal leaflet of the tricuspid valve. So that stitch there is just through the leaflet. You have to be very careful not to pick up any fibrous tissue or muscle. So now the suture is actually in the right atrium, and then we pick up a soft pledget and pass it back through the septal leaflet a little bit further along and now the needle is back in the ventricle, and now you've sealed off the corner of the VSD. You can pass the two needles through the patch. And then tie it down. So now we move on to the arterial switch component. I say the first manoeuvre is to transect the aorta. So you're looking for where the sinotubular junction is, and you want to be well above it, probably about 5 or 6 millimeters above it. And you're trying to make a perpendicular transection of the aorta, perpendicular to the long axis of the aorta. And as soon as you've opened up, the first thing is to look carefully inside and make sure you get a good understanding of where the top of the commissures are and where the coronary ostia themselves are. It's always very helpful to put in stay sutures that are in the living heart are just partial thickness, and those not only are going to show you your best view and allow you to manipulate the route around as you work on it, but they also show you exactly where the commissures are. So one suture goes at the top of each commissure, and so keeps your orientation correct and guides you in taking out the coronary buttons. And here the commissure is in a typical arrangement with the commissure posteriorly directly in the middle facing the pulmonary artery. So you really take care to identify the position of the coronary ostia, and I usually start by taking the right coronary button. And the scissors stay right up hard against the commissure of the valve, because you really want to maximise the amount of tissue you take out in your button. So really hugging the attachments of the valve leaflet to the sinus. So you really take out pretty well the entire sinus together with the coronary ostium to give yourself the maximum amount of tissue. So here the button's starting to appear. There's the ostium. You need to then, once it's free from the aortic wall, make sure it's nice and mobilised. Left coronary button's exactly the same, coming down at it from above, and as soon as you get past the sinotubular junction, it opens up, and you carry on doing exactly the same and trying to take out pretty much the entire sinus. Every millimetre helps you. And trying to make sure you've got a lot of room free from the ostium itself. And then you would normally use cautery just to free up the button, allow it to lift up to be free. Obviously in these models you haven't really got that connective tissue, but the key is to understand the position and orientation of the coronary. I would always probe it very gently with a coronary probe and make sure you understand its course and where it's going to want to sit on the aorta. So now we'll transect the main pulmonary artery, exactly the same, taking care to transect it pretty much perpendicularly to the long axis of the vessel, and try and keeping it as high as possible but without encroaching on the branch origins of the branch pulmonary arteries. As we look down there now through the pulmonary valve, you can see the tunnel that we've created by committing the VSD through from the ventricle. In Taussig-Bing, also really important now to look through the aortic valve, which of course is going to become the neopulmonary valve. And you're looking down through the right outflow tract to be absolutely sure there are no muscle bundles or obstruction beneath the valve, which you can commonly see in Taussig-Bing because of the deviation of the septum. But that looks wide open beneath the valve, and so it's not going to be a problem. So now you can return to the pulmonary route. Place 3 sutures in exactly the same as before, one at the top of each commissure to get your bearings and keep your orientation. And then we can work out exactly where to implant the coronary buttons. So I would always start with the left coronary button, the coronary coming from sinus 1. And we'll make medially hinged trapdoor incisions, really trying to allow the coronaries to tell us where they want to be, so that they're sitting in their position of least rotational torsion. So here's the left coronary, and you can see we're just holding it up in the position it wants to be. So you can imagine how it's going to look as it's moved across, and you can see the coronary on the surface of the heart, that it's not going to be distorted. And pretty well always, it's in the middle point of the sinus. So this is the medially hinged trapdoor incision. So first going straight down in the middle of the sinus. And you're imagining exactly how the coronary is going to sit there. And then a medial hinge to create a little trapdoor to let that flap open to come out to receive the coronary button, so it doesn't have to twist towards you. So this is implantation of the left coronary button. I start at the top and work my way down towards the apex, but I think it's often good practice to start at the apex when you're just starting out, to make sure that you orientate the button exactly as you want it to. But this is a nice way to keep yourself moving fluidly. We bring the button down And when we get down to the apex, which is where the little trapdoor is, you'll see that we can then change direction and you move your body position and then come up the medial side of the suture line. And all the time you've got half an eye on exactly where the coronary ostium is and where the valve leaflets are. And it's really important, again, as I keep emphasising, that taking that nice big button means your needle passes don't have to go near the ostium itself. So here we are now, coming up the medial side. And the whole button's been kind of folded in. So here it is coming up to the top, and then I would lock the sutures at each side of the completed button once you're happy. But once I've finished the suture line, I always then probe the coronary and be sure that I'm happy with its position before locking the stitches. You can often end up with a small amount of redundant button sitting proud above the height of the transected aorta, but that's not a problem. You can just cut that away once you're confident and happy that you've got the position right. So now we move to the right coronary, or the coronary coming from sinus 2. And it's exactly the same process. Again, you allow the coronary button to try and tell you where it wants to sit, and it's usually about in the middle of the facing sinus. So again, it's a medially hinged trapdoor incision. Here's the first longitudinal part, and then the trapdoor coming across medially to open up that little flap. Sometimes the incision ends up being more of just a swerving, curved incision without such a prominent sort of trapdoor component to it. It depends on the position where the right coronary wants to lie. These stay sutures are very helpful, but you always have to be careful to make sure you're not putting on too much torsion on the tissues, because they can easily distort the position of everything. And you can just see us here just trying to get the retraction on those sutures just right. Here's the right button. You see how it's just sitting naturally where you want it to be. You're not having to put it under any torsion or tension to bring it to where you're going to implant it. It just sits there naturally because that's where it wants to be. Again, we start at the top and work our way down. And all the time you're just eyeballing everything and making sure that when you reach the nadir of the button, it's going to be at the nadir of your trapdoor incision, so that you've got everything matched up nicely. And then again, once you get down to the nadir, you can turn your sutures over and then fold the flap in by changing direction with the suture. So see how we've moved the stay suture to come now up above, and that rolls the aortic wall towards you, and you can run up the medial wall. Again, trying to keep your movements as fluid as possible with a constant sort of over and over suture. It is less forgiving, these plastic printed models. They're not so easy to suture to as the silicone models that are a bit more elastic, but I think if you can get it looking good with these plastic models, then it'll be even easier with the real thing. So there's the completed coronary buttons. So here you can see the completed buttons sitting in a comfortable position, so that you can follow the position of them on the epicardium, and they're filling nicely. Again, it's always helpful just to probe the orifices themselves so you can see that they're widely open, and you want to be able to see those two buttons sitting there comfortably in their natural position without any torsion. So that's the basic components of the arterial switch. Obviously, in the setting of this Taussig-Bing heart, you could see that there was some arch hyperplasia, and that we would want to repair the arch with a patch. And the best way to do that is to split the whole aorta all the way back down to the point where it's transected, so that you place an augmentation patch around the whole arch and down to the point where you've transected the aorta. And this means you've got a much wider circumference, so that when you anastomose the two components of the neo-aorta together, there's much less mismatch in size, and it makes it easier to perform.